The final presentation from the STS Research 2 category is Breast Cancer Imaging and Risk Perceptions, the Role of Media, Trust, and Control by Michele de Rieux, and her project advisor was Professor Peter Norton.
So my topic was breast cancer imaging and risk perceptions, the role of media, trust, and control. So in 2014, there were more than 40,000 related breast cancer deaths. Mammograms, mammography, are the most common screening technique that are currently used. However, they have a number of trade-offs, including false positive results, radiation exposure, and overdiagnosis. All of these are cumulative effects. So in looking at trends in mammogram use in recent decades, I formulated my research question: how can we explain breast cancer screening practices in the United States? So first off, screening is a voluntary behavior. Patients must balance kind of perceived risk, perceived benefit. And it's important to remember that there are alternatives to mammogram screening: physical examination, MRI, breast ultrasound, and there's also new techniques called tomosynthesis, which is a 3D mammogram. So in examining patient behaviors, I really looked at a couple psychological models of risk. One is message framing. So there's been recent studies that lost frame messages actually increase mammogram behavior. There's also a number of risk perception pathways that apply here. One I have on the bottom right is a model that has an additive function of susceptibility and severity to modulating behavior. There's also this idea of media-driven social amplification of risk. And sort of in regards to all of these topics, the question becomes, how can we connect these and sort of explain breast cancer screening? So this is the mammogram battlefield, so to speak. There's a number of participants in this kind of hotly debated issue. So in looking at all of these and examining the literature, social media, published works, my thesis was that advocacy organizations, trade associations, manufacturers have exploited emotional and fear-driven biases to change screening behaviors. So some central tenets here are that in the 1960s and 1970s, soon after mammograms were used clinically, very few women actually have any sort of mammogram, not even regular mammograms. Then in the 1980s and 1990s, with the advent of many advocacy organizations, we see sort of widespread screening practices that are adopted. Here we have 71% of women 40 and over have had at least one mammogram. So in recent decades, we've seen the shift toward informed decision-making models between physicians and women. And so all of these point to the fact that mammogram practices are really an intricate battle of opposing visions of what people say is safe and effective healthcare. So there are really three central tenets here: that is media and message framing, trust and patient control, and conflicts of interest, misinformation, and I'll go through these as quickly as I can. But so advocates typically use this idea of kind of it could happen to anyone messaging. They really leverage social media platforms. On the bottom right is a Twitter clip from the American College of Radiology's Mammography Saves Lives campaigns. There's also sort of this idea of exploiting naming conventions historically. So you can actually quantify the change from the term breast x-ray to mammograms between the 1970s and 1980s. So this idea of trust and patient control is really governed by a number of relationships. The key ones here that I've cited are physicians and patients, feminists and patients, which I've kind of lumped together under the idea that women are kind of empowered, in control of their health, so there's no one-size-fits-all approach. And so also in recent years, manufacturers have targeted patient anxiety and safety concerns through technical development. That's the idea of these 3D mammogram techniques that are supposedly supposed to reduce the risk of false positive results, reduce the amount of radiation, all that kind of stuff. So the last tenet here is conflicts of interest, misinformation. This is typically cited by those opposed to mammogram screenings, and they really sort of cite exaggerated misinformation that sort of cite this idea of population-based screening methods. There's also financial conflicts of interest in the industry, and they cite that there are actually safer, more effective alternatives. So to wrap up, why do we care? Improved patient outcomes are achieved at this interface of diagnostic capability and social acceptance. That is, better technology is not the only factor that really drives patient adoption. And so the case of breast cancer screening really illustrates this growing influence of media on patient perceptions as information is more rapidly communicated in this network. So I'll jump to the final figure here, and this is my key takeaway, is that I think this really speaks to a shifting medical system towards from population-based medicine to evidence-based medicine, which is an individualized, personalized approach. And the term I'm going to use here is big media, which is sort of the manipulation of large, accessible amounts of data in sort of modulating this network. So that's all I have, and thank you for your time.